I would say MSF has raised the bar extraordinarily well in terms of evidence.
It's really an opportunity to learn about what have these field teams been doing.
It's kind of like a broadcasting platform to the humanitarian sector at large.
There's a clear move to try and look at research that's being done that can actually then change what we do.
Millions and millions of people in Syria, South Sudan and Central African Republic, to name just 3 of the major crises that are currently occupying MSF, are not receiving the assistance that they need. Collectively, we need to do better. Central to these efforts is the role of research and evidence in these extremely challenging environments.
One of the questions which is kind of bouncing around our HIV programs and also in ministries of health at the moment is if we have access to routine viral load, do we need to keep going with routine CD4 monitoring? There's an emerging body of evidence to suggest that patients or not who are virologically suppressed are able to maintain their CD4 counts over time. And where routine viral load is available, CD4 monitoring could be reduced or stopped altogether. But baseline CD4 will continue to be important for clinical decision making and decisions around the use of prophylaxis.
The role of MSF in Papua New Guinea is that when we came first, we looked at the enormous suffering of survivors of intimate partner violence, sexual violence, and a lot of children being sexually abused. These survivors are not just numbers. They are women, boys, and girls. They have been raped, they have been beaten, they have been sexually abused, and most of them by their intimate partner, their parents, or other known people. Survivors will come for care when free, accessible, quality, and confidential health services are known to be available.
Borreliosis is a very severe, destructive, disabling disease that especially affects children in rural, remote areas, but also adults. But it's really very neglected. There are minimal people working in it. There's not been a huge amount of operational research done in it. And MSF's filling a really important void of actually treating people with this severe disease, but also through treating and studying what we do, actually finding out very important scientific information, which is helping improve treatments down the track.
I'd like to thank the organisers for giving me the opportunity to present on behalf of my colleagues what I think is a really interesting and important example of how MSF operational research in a neglected disease treatment program, in this case borreliosis, can have an impact on international management guidelines. An MSF program focused on the neglected tropical disease of borreliosis, which was very important in actually treating the disease, but through clinical practice and the study of observational data, allowed the acquisition of important knowledge regarding the clinical and epidemiological interactions between borreliosis and HIV disease, the information of which was not really available from other sources. And this was very important in building simple, common sense, preliminary international guidance for the management of borreliosis HIV co-infection.
Scientific Day is important because it gives me an opportunity to present how I think we might be able to do our work better to an audience that is able to enact that change and allow us to take action. Why the world pays so much attention to Ebola is a good question. It isn't because of the burden of disease. It isn't because of the number of people it kills or how much economic impact is there. But for some reason, it's fascinating for all of us. and it gets people's attention, and MSF is the only medical organization that responds. And if we step away, who's going to take our place?
There on the bottom, that is a slum in a swamp in a city called Lubumbashi in the Southern Democratic Republic of the Congo, and it is mapped down to the individual building level. So that is a citizen-generated, volunteer-generated map to which we can begin to start looking at genuinely linking our patient data to real things in the real world.
Question from MSF Zimbabwe. How do you map places without streets or roads, the real remote places?
But with modern technology and data techniques, it's increasingly possible to translate what people themselves use to describe their location into something that we can actually use. So every society has a way of describing location unambiguously. It's just a matter of us learning to speak their language, having some respect for the local culture and assume that they do know where they are, and starting to translate our systems to fit theirs. That would have been very, very difficult even 5 or 10 years ago. With modern technology, it's increasingly possible.
As you all may know, visceral leishmaniasis, or Kala-Azar, which means black fever in Hindi, it's a neglected disease classified by WHO, and it's fatal if untreated. So we engaged with the NDI and the Indian government to develop a pilot protocol to study these phase 3 trials in a wider range of patients in routine program settings to catalyze this policy change. So the results as initial cure rates or early outcomes in Kala-Azar, out of the 1,171 patients recruited, we had very good results. So all the 3 arms had more than 99% of efficacy of initial cure rates.
What happened when a health center was facing a shortage or a stock out of a drug, of an antiretroviral or TB drug? Well, for 20%, people were sent back home or sent back to another health center, but without any drugs from where they were coming. We have a first civil society stakeholder meeting by which we achieved as well and triggered out basically the Ministry of Health to think on alternative supply systems through public-private partnerships, through potentially supermarket type of delivery of drugs, certainly where people are living further away from health centers. But civil society initiatives like this can act and should act in parallel with the national systems in order to monitor as a watchdog does. But let's also not forget that this stresses once again that in chronic and lifelong treatments like the one for HIV and TB, the patient stays crucial. The health worker from the low-level staff, the one that we usually work with as an organization, together with the patients, are the most crucial components in partnering for improving health care delivery.
So MSF very rightly focuses on the treatment of patients rather than the treatment of health systems. But here we have 4 excellent studies which actually, the results of which has the potential to catalyze change in a big way.
The work I'm going to present today is called Humanitarian Water at Risk, Chlorine Decay in Refugee Camp Water Supply in South Sudan. Here we were trying to meet the humanitarian guidelines for safe water supply. In essence, the guidelines we're using for emergency response are based on no evidence whatsoever from emergency settings. So in response to this evidence gap, we launched a study in Jamambati and Jindrasa in March and April of last year to look at the water quality and water handling practices. In light of the rapid decay observed, we recommend that we make a tentative recommendation that the guideline for chlorine be revised to 1 milligram per liter in all situations, whether it be an outbreak situation or not. This is because on the basis of the modeling outputs, we can expect to have 0.2 milligram per liter of protection, of chlorine protection, up to 10 hours out with this guideline.
What we have learned about best practice in emergency settings, both protracted conflicts, but also rapidly growing refugee settings. What we know about priorities and best interventions in many ways has been contributed by MSF and its teams of researchers. We are looking at the problem of medical relief to trapped populations in mass atrocity conflicts that will last for years to decades. That is what we're looking at right now. The aim here would be not to keep them alive solely, but to help them live, because this will be their life.
How can activism, the outrage at a problem like the lack of provision of drugs for patients, provoke us to do a simple study in a short time that gives us more evidence to do more effective activism? Hopefully we can be challenged and take away the short quote from Jennifer. It's not just about keeping patients alive, it's about helping them to live. Please carry on the discussions. Thank you to all.